Another wonderful area, sort of spearheaded by my friend Oliver Sartor. So, I think PSMA-guided, radiopharmaceutical treatment, whether you do it with beta emitters or alpha emitters, is being studied currently. I think its role in metastatic castrate-resistant prostate cancer that's gone through several lines of treatment is unquestionably sound. We know that study, and there are multiple studies now moving it back into earlier disease states. So I think it's helpful because it can target areas that we cannot see easily. The limitation of this is going to basically be whether the cells take up, for example, PSMA or not. And as you get into cancers that are more aggressive, for example, the cancers that are not androgen responsive, the low PSA, high-grade cancers, PSA less than 4, Gleason F-score 8, 9, or 10. These are traditionally not sensitive to ADT, and the question is whether they uptake PSMA or not studied. But those cancers kill people at a very high rate, much higher. A standard 8, 9, or 10 might take 20, 30% of people's lives. But one with a low PSA and an 8, 9, or 10 takes about half of people's lives who get this disease. So, that's the limitation is, PSMA is number one, but is there anything else that we can find that targets prostate cancer more ubiquitously, in addition to PSMA, which is sort of the beginning, so that we don't miss any cells? Because you can imagine this for a moment. If you could find something that targets prostate cancer ubiquitously, then you're done, right? Whether it's a radiopharmaceutical you tag to it or something else that's toxic, if you have the ability to really deliver treatment to where the cells are and do it in a way that the circle of destruction that you create is small enough so that nearby tissues don't become affected, then you're done. One last thing though, and I've brought this up before, in metastatic castration-resistant prostate cancer, using radiopharmaceuticals tagged to PSMA is fine because those poor men don't live very long, 1.5 years, 2 years at most. So as you move this back, and now you're treating, bone marrow where these prostate cancers live, you have to wonder, since we know radiation is carcinogenic, whether if that person lives long enough, we're going to cause a transformation in their bone marrow to create a myeloma or a leukemia or something else. That's not been observed, but I'm just putting it out there as a word of caution because we have to think about that. The one thing I do like about targeted imaging, though, is lymph node treatment. If you think about it, because the lymph nodes, are in the abdomen and pelvis, thorax. They're far away from bone for the most part. And they often are not easily treated. You can't dissect them all surgically, and radiation has a limit in terms of how much you can deliver to sterilize them. And so that's a nice area, I think, for future study in terms of radiopharmaceutical directed agents is lymph node